This is not a commercial presentation.
Это не коммерческая презентация, в первую очередь.
This is a presentation of clinical experience, not just by the speaker, but by the audience as well.
Это представление клинического опыта, собственного и множества других фактов.
So my name is S.Levine, and I am from Connecticut in the United States. Connecticut is just next to New York. I live about an hour outside of Manhattan. And I am on the clinical staff of Yale University. So in the United States, we always disclose any financial relationships. So I'm going to be very honest and disclose that thank you to Elman and Sergey. They took care of my coming to see you. So welcome to my clinic. This is my office. This is my patient. And it's just from all the different rooms. I have one room, one place in my office, which is where I do all of my procedures.
Это клиника доктора Левайна, это его пациентка.
And so you can see I have a OR table, I have lighting, I have a video board, I have places to clean, I have my Elman IEC2, and I have my happy patient, and this is the bipolar turbinate probe, which we're going to use for her.
То есть это вот все компактно, все разнообразное оборудование, которое он использует для операций, включая в частности и сорбитрон Элман.
Every time I do a procedure, I keep this formula, this mathematical formula in mind. This is, if there's one thing I want you to get out of my talk, it's this slide.
Перед началом любой, так сказать, манипуляции с помощью радиохирургии я всегда помню об этой формуле, об этой магической формуле. Она означает, что теплота равна площади поражения, умноженная на время, на мощность и деленная на частоту.
You told them what the slide says?
No, I've been the formula is on.
So the formula says heat. The lateral heat in the soft tissues, the biologic tissues we're treating, is directly proportional to the size of the area to which the energy is directed. The greater the area, the more heat we're going to generate. The limited the area, the less heat.
Теплота в тканях прямо пропорционально зависит от размера области, так сказать, применения этой энергии, длительности применения энергии и мощности источника энергии.
It's directly proportional to the duration of exposure. So if we cook the tissues, we're going to generate more heat. If we direct very short bursts of energy, we'll have much less lateral heat.
То есть если мы длительно воздействуем на ткань, у нас больше тепловое, так сказать, повреждение. Если мы делаем это точечно, то его значительно меньше.
And the last thing on the directly proportional is the power. So the higher the power, the more heat. Lower the power, the less heat. So we look for this nice balance between just enough power, not enough to get a lateral heat, but just enough to get good cutting. You'll see that in a second.
То есть очень важно, чтобы мощность, фактор мощности он регулировать, чтобы выбрать именно ту мощность, которая оптимальна.
So let's do some clinical cases. My practice is a combination of some general otolaryngology as well as some cosmetic. And I'll show you some of the cases from my collection of pictures. So this is a patient who presented with an old otoplasty. He had an otoplasty. This guy's in his 50s. He had an otoplasty when he was a teenager.
Этот пациент делал отопластику еще будучи подростком, а сейчас ему 50 с чем-то.
And he was disappointed because this was all flat. And he wanted to get his curve back to his ear.
Ему не нравилась форма вот уха, вот именно в этой части.
So you have an old scarred tissue, destroyed cartilage, scar on top of cartilage. The worst case you could imagine, right?
Самый плохой случай, потому что была старая, так сказать, рубцовая ткань и все, так сказать, последствия старой операции.
But to address it, we made an incision in the postauricular crease. We dissected with a empire tip needle down to the cartilage. And then this probe, little triangular probe, is what the ophthalmologists use for doing tarsal strips in the eyes. wonderful for trimming, for cutting cartilage.
Он сделал разрез таким электродом, это Empire Needle, который используется офтальмологами при блефаропластике. То есть разрез тончайший и очень, так сказать, точный.
You can cut cartilage like you can cut butter with this. It's that good.
Резать, как режется масло.
So we were able to get his back is curved. We put in a couple of Mustardi sutures and we called it a day, and he was very happy. Everybody sees this. This is a gentleman who fell out of a chair, and he has a hematoma of his ear. Right? So, what do I like to do? I'll make an incision in the postauricular crease. I'll then take the same tip that we use, make my little incision in cartilage, open up the from posteriorly, drain the hematoma, get complete decompression, and then I like to do this to put pressure. So I'll have a drain, bolster dressings, through and through stitches, leave that in for 2-3 days. So here's an African American with a big keloid on the earlobe, right? And again, excising the entire keloid, rotating a skin flap forward. We can do this bloodlessly, and if you've noticed, this is everything I'm going to show you, I do in my clinic. Local anesthetics, no anesthetic, no general anesthesias, all local anesthetics.
Все он делает у себя в клинике только под местной анестезией.
This is easy. This is a keloid, little keloid on the tip, right? Shave. And you can see how beautiful that comes out a few weeks later. This beautiful girl was going off to university, and she had a mucocele in her lip. I love surgery on the lips. This is the best tool for lips. And she had a bump here, and she didn't like it. I don't blame her. And with lips, we really can get a bloodless procedure. No bleeding. We make our incisions. We can do a nice full dissection. Unfortunately, you see I got a little bit of blood. I apologize.
То есть даже на губах получается, что бескровная операция.
And when it's bloodless, you get no hematoma, and you get very little swelling, and you can accurately place your sutures with good eversion and get a good cosmetic result. This is a young lady who had this. I don't know of a plastic surgeon who likes seeing this in his office. Nobody likes this, because these are intradermal melanocytic lesions that go deep into the dermis. And what we can do with the Elman using the loop is we can do serial excisions. So we can put local anesthetics in here and excise using the loop so that we get down to the dermal layer and then let it heal in by secondary intention. And that's the kind of results we can get.
То есть эта процедура делается петлей, пошагово снимается.
So I do a lot of sinus surgery. Or let's put it this way, I've been doing a lot of sinus surgery. In the States, we're going to talk about balloons a lot, I think, at this meeting. I do also a lot of balloons, and I think as time goes on, the balloon is going to reduce the number of full sinus surgeries we do. But that's okay. With sinus surgery, with septal surgery, with rhinoplasty, we all get synechia. We all get some scar tissue after the pack comes out, or we see someone else's patient. The patients you look in their nose, you see the scar bands, and it's so easy to make this better. All we need to do is put a little local anesthetic, and using our endoscopes, we can do nice cutting and get rid of the scar band. The key is the follow-up. The key is to see these patients back every week and to clean out the crust and let it heal until the crusts are no longer there. And then you will not get recurrence of the scar bands. So this is one that's from inside the ethmoid. Okay? So this is a band between the turbinate and the lateral wall of the nose. You can cut those. And you can see how I'll use hemo, right? I'll coagulate first and then cut, especially when I think it's vascular tissue. And I can open that whole area up. This is a patient who had endoscopic surgery, and then the maxillary sinus ostium closed. Every now and then I can get a good video in my office. And so all we're doing here is using the element, and I'm concentrating on just the posterior wall of the ostium, right? Because we don't want to go circumferential on the ostium. That'll cause it to close again. So just the posterior wall in the ostium in order to really open it up a little bit better. All right, how many times does a patient come in with recurrent nosebleeds, and you look in the nose, and they've got this mass right at the top of the septum, right where the septum meets the scrolling of the upper lateral and lower lateral cartilages at the nasal valve, the toughest part of the body to try to take something out without getting scar, without getting synechia and the nasal obstruction. So with exposure, we can get incredibly good excision, bloodless excision, no interruption of the mucosa of the valve area, and get a great result. Nasal polyps. We all see patients with nasal polyps. I love doing nasal polyps. I like taking out nasal polyps for two reasons. One, right away you make the patient feel good. Two, you have tissue diagnosis to make sure you didn't miss an inverted papilloma or another malignancy. So, my lovely patient, polyps on both sides, afterwards without the polyps on both sides. And using this polyp snare is very easy, right? Just like any other snare that we've used for hundreds of years in otolaryngology. And as you squeeze down on the snare, you give it some energy in order to coagulate as it cuts. Bloodless polypectomy. So my flight was on Sunday. This patient comes in on Friday. This is my last patient I saw on Friday. He comes in with recurrent nosebleeds. And this is what he has. Telangiectasia. And this is how we get rid of it. And you get a great eschar with no bleeding, no recurrences, perfect, good result. Later this afternoon, we're going to talk about surgery for allergic rhinitis. This is turbinate reduction. So using the bipolar probe, place that internally into the turbinates, again under local anesthesia. Personally, it depends on the severity. I will provide somewhere between 6 and 10 on the power setting and give about 10 seconds of energy to each turbinate. I will sometimes inflate them with saline depending on how big the turbinates are. All right, so I'll just describe it. So this is just showing you actively what we do. I've already injected the turbinate with local anesthetic. I've waited about 5-10 minutes. Placed the probe deep into the stroma of the middle turbinate. To do this is important because you don't want to get any coagulum of the mucosa. Avoiding that coagulum means you'll have less interruption of mucociliary clearance, and that's important. And then I'll apply 6 to 10 seconds altogether of energy, depending on the power setting. So, again, both sides were treated, and I think this afternoon I'll have to make sure that if we can get someone from technology, because I have other videos, and if we can get sound through the sound system, through the laptop, I think that'll be helpful. All right, we'll work on that for this afternoon's talk, okay? So what I want to show you is this is what it looks like afterwards. This has been treated, okay? There's no coagulum. There's no involvement of the mucosa. The turbinate's been reduced. This is immediately after I did the procedure. Gesundheit. Here we go, the other side. See? This is the entrance point, a little tiny bit of coagulum at the entrance point. Yeah, we need a cable, yeah. Okay, so more on the nose. This is a woman who had a little nevus on the tip of her nose, stuck out like a witch. And this is the result 3 months later. Just shaving it down. The picture makes it look worse than it actually is. And I always like a lecture when the surgeon shows his worst results, not his best results, because it makes us all human. So this is not a great result to me, but the patient's happy.
Это не лучший результат, но я люблю показывать как раз не самые лучшие результаты, а вот не самые удачные, потому что удачные хвастаться.
And then there are other great results. So they're the ones where you kick this nevus off, and again, all these little cosmetic things, more dermatology. Right here's the nevus. Immediately with excision, 3 weeks, 11 weeks post-op. No sutures, no closure, just healing by secondary intention. That's 2 years later. Woman of color. Again, you can see the pre-op, 6 weeks post-op, 1 year later. We all like snoring surgery. We take care of a lot of patients who snore. I noticed in Russia, men snore too. So this is your lay-up, ray-up, radio-assisted uvulopalatalplasty is what we call it. And again, nice long uvula. Huh? So we'll make our tranches. We'll cut off the uvula, make it shorter. Easy. Leukoplakia. We're seeing in the United States a rapid rise in oral cancers. Michael Douglas, famous actor, just announced how he got his cancer. He blames it all on oral sex. Have you heard this? No? All right, so the incidence of human papillomavirus-induced squamous cancer is going up dramatically. And Michael had his surgery in New York. And he then went to People magazine or on Entertainment Tonight or something, and he announced, I know what caused my cancer. It was from oral sex. So now we have thousands of men coming to see us in the States, all afraid that they have oral cancer. It's very interesting. But I like this technology for leukoplakia, and here's why. Because I can do a wide local excision of a tongue in my office, in my clinic, with local anesthetics only, and I can take out the entire area of leukoplakia. And when I can send that to my pathologist, I know if there's cancer or there's no cancer. If you destroy leukoplakia, if you do a biopsy, you take a sample and you destroy it, what have you done? You've sampled a little teeny piece of hay in the big haystack, and then you destroyed the haystack. This gives me much better idea of what I've got and what I'm doing, and this is the kind of thing that also can heal by secondary intention. No sutures. Just let it alone, it'll heal.
Я поясню, может быть, не все понял, что материал, который убирают из языка, он идет на гистологию, и можно определить, все-таки есть рак или нет. И все опять заживает вторичным движением.
So this is 1 week post-op. It shows you what it looks like with the granulation tissue. And this is a gentleman who 2 years ago, I actually did a partial glossectomy. He had an invasive squamous cancer. We did a wide local excision of the tongue and let it heal in by secondary intention, and that's 2 years afterwards. Many of my colleagues would put a split-thickness skin graft and do this under general anesthesia, and you get that white, dry skin if you use a skin graft. If you let it heal by secondary intention, you actually get mucosa with normal function. Leukoplakia of the soft palate, again, very easy for all these potential oral malignancies. And these are pictures courtesy of a good friend of mine who's at Montefiore, Dr. James Goodrich. Dr. Goodrich is a pediatric neurosurgeon who is famous for dividing Siamese conjoint twins. And he is a fan of the Elman. So he sent me these beautiful slides where they planned out the entire surgical procedure. And he divided the corpus callosum using the Elman. Now, if a neurosurgeon dividing Siamese twins is convinced this is the best procedure for less lateral heat, you can bet that's a good testament. Both children lived, and this is a very good happy ending, very famous case. So, what are our lessons? For cutting, the least lateral heat. We can do that on the skin, whether it's the face, scalp, and neck. We can do that on the tympanic membrane. I have Dr. Yabe in Tokyo has really focused on using the Elman through the otologic microscope to ventilate the middle ear for about 2 to 3 weeks. It's excellent. Then you get healing and closure. In the U.S., we put more tubes in than we leave them open, but you certainly can do that. Great for cutting cartilage. Fantastic for cartilage. Good for rhinoplasty if you're doing cosmetic rhinoplasty for cartilage. So for skin, I use it for all my incisions. I use it for all of my excisions with healing by secondary intention, including rhinophyma. And then I'll do my excisions even with repair. So if I have to put sutures in, that's okay. Myringotomy we already mentioned. I showed you the otoplasty and decompression of an auricular hematoma or seroma. When we use the cut coag, this is the combination now of cutting and coagulation, I like to use this in mucosa. So, lesions of the nasal vestibule or the nasal cavity, polypectomy, synechia between the septum and turbinates, synechia of the sinus. And in the oral cavity, oral pharyngeal and laryngeal cavities, we can again use this great tool for mucosa. Lesions of the lip and buccal mucosa, palate, minor salivary glands, wonderful for getting minor salivary gland tissue and the lip. Leukoplakia with preservation of the specimen. I have colleagues that like it for tonsillectomy and adenoidectomy. And of course, colleagues who are very much love this for laryngeal surgery. Excellent tool for that sort of thing. And then when we have the most lateral heat, radiofrequency tissue reduction of tissue. We do this tissue reduction for the inferior turbinates, soft palate, tonsils, base of tongue, and then for control of hemorrhage. So all those situations. And then finally we showed you the spider veins. Okay, on to the next speaker.